fine.
Okay.
Hello, Ruli.
Hi, Rule.
How are you?
Rule, how are you?
Hello, Dr. Fanous. How are you?
هاي ازي حضرتك؟
How are you? Good to see you all.
Thank you.
Okay, we're ready.
So, Rule, did you have the chance to adapt to the cave?
Excuse me?
Rule, I'm just asking if you had the chance to adapt the cave to shorten it.
I have the case, but it's still in my team laptop. I think I believe Dr. Lukman, it's here.
Okay. Yeah. No, the cave, the second cave from Professor Maziad that I was asking you to present. Okay, so just in between, we'll be starting soon. So in the interest of time, as we have been doing in the other sessions, we are asking the faculty to present the cases and to try to make it more easier and more streamlined to save some time as well, and to stay out of some details. So we'll try to enhance and to enhance the discussion and to value more this. The most important thing is to give some educational remarks and recommendations. So each
Can
of
I
you
have a question, Paulo?
please.
During the discussions, is it what you want is that we talk to each other as panelists, try to tell people what to do, or you want us also to include some of the participants themselves? I see some very good number around, and so if you want to let them be able to join, if we ask them, that would be fine.
Yeah. The thing, the way we have been doing it is that they usually they put their questions on or the opinions on the web on the chat.
On the chat,
yes. And the chat, and we'll try to go from there. Okay.
Very good.
So that's to try to avoid, because when it's a lot of people, when you open and close the microphones, it gets a little bit confusing. Okay, so we are on time. So I would like to start this session and to start thanking all of you for joining this monthly one more of this monthly session of the spine board. So the way we are doing this, as on the previous sessions, is not to try to show different and very complex cases. It's like everyday cases, and we try to set this as we do in our department. So we bring with the case, we discuss among the faculties. So please interact. Please put your questions in the chat. So put your opinions. So the way we are doing it is that each of the faculties will present one case. These cases are not from their own, but from other parts of the world. So we will acknowledge the submitters of the cases, and then we will discuss the cases among the faculties. So this includes you, of course. So we want to foster active participation from all of you. So please put your questions, please put your opinions, your comments on the chat, so that we can foster the discussion here. So today we are fortunate that we have an outstanding faculty, including Dr. Andrew Fanous from University of Virginia. He's an assistant professor of neurosurgery. We have Dr. Ruli Dallen from Bandung, West Java, Indonesia, and Professor Sawood from Ain Shams University in Cairo, Egypt. So with no further delays, I would ask Dr. Andrew to present the first case that has been submitted by Dr. Uzair Siddiqui from Karachi. Please.
All right. So yeah, good morning, good afternoon, good evening, wherever you guys are. Thanks for including me in today's session. And thank you, Dr. Pereira, for the introduction. So I'm presenting today a case by Dr. Uzair Siddiqui from Karachi. I don't know whether or not he's on the meeting today because we may have some questions for him. But can you guys see my screen here? Perfect. So this is a case of a 6-year-old gentleman who had a previous history of spine surgery about 1.5 years ago. And he presented for bilateral sciatica and progressive neurogenic claudications initially, and that was the reason for initial surgery. And then now he presents 1.5 years later with inability to walk or stand for more than 20 minutes. He does not really have much back pain or any problem with his sphincter function. On exam, his dorsiflexion was weak bilaterally, so 3 out of 5. Same with EHL. His plantar flexion was 5 out of 5. He had decreased deep tendon reflexes, and otherwise his exam was unremarkable. And just by looking at his examination, you can sort of localize the lesion or the problem to the probably L4, L5 level. This is an X-ray of the previous surgery he had, and kind of the first question I asked myself was, this gentleman presented with claudications and sort of difficulty with walking, and why did he have such a long fusion surgery? It would be helpful to see his preoperative images and understand the cause for such a large construct. But for someone with neurogenic claudication, he's not that old. I'm a little bit surprised by such a large construct. These are the images we have currently for the patient. They were not very clear, but I was not very impressed by them. You can see these are the pedicle screws. Overall, the central canal does not seem to be compromised. So same thing with the MRI here. So this is the central canal. You can see all the caudal nerve roots. You can see the conus. I don't see any impingement of either. Difficult or more difficult to tell if the foramina are involved on axials. So I do rely on what Dr. Siddiqui is asking here in terms of questions. Of course, he has access to the images themselves. So he can tell that there is some medial breach of the screws at L4 and L5 on the right side, and has bilateral breach at L3. So the question is, what would be the further management for a patient like this? And the options that he's asking about are either re-exploration and revision of the distal screws, re-exploration and decompression of the canal and nerve roots with removal of distal screws. So my take on this is very simple, is I believe we need more information before we can come up with a decision for this patient. If you look at initial presentation of the patient, he's presenting with inability to walk or stand for 20 minutes, but really no back pain, no other neurological dysfunction. His exam, it's unclear whether the weakness he has in his feet is caused by his presentation before the initial surgery, or it is something that he developed more recently. If this patient is in my clinic, the first thing I would do for him would be to get EMGs and nerve conduction studies and try to understand, does he have active denervation coming from his L3, L4, and L5 levels, or are all these findings chronic? So that's number one. Number two, With such a large construct, I would probably also try to get scoliosis x-rays. I would try to see if there is any sagittal imbalance when the patient is standing up. I would also try to understand the reason why he cannot walk for more than 20 minutes. Is it claudication or is it more balance problems? And if it's claudications and looking at his MRI again and not seeing that much canal compromise, probably I would send the patient to a vascular surgeon and make sure he does not have vascular claudications as opposed to neurogenic claudications. And of course, in our practice, we send everyone to physical therapy to see if that helps with the symptoms. So again, my recommendations would be EMG and nerve conduction study, scoliosis x-rays, possibly sending the patient to vascular surgery to rule out vascular claudications, physical therapy, and I would see the patient again after all of those tests and evaluations are done, and then make more decisions. But I'm happy to see what everyone else thinks.
Okay, thank you, Andrew. So maybe we go now to Professor Sawood to see his comments on this case.
Can you start Paulo, can you start by Rolly? Because I was seeing my last patient.
Okay.
So I will revise, no, and I will comment after Dr. Rolly, okay?
Okay, perfect,
okay,
perfect. Rolly. And again, I would like to ask all of you to put either questions or comments or recommendations or suggestions or whatever you feel relevant regarding this case to add on, because the main purpose of this session is really to discuss and not that much what was done or what can be done. So, Rolly?
Question from Dr. Shah, if the patient has any sensory deficits. According to this presentation, he does not.
Yeah. Apparently, it looks like a motor deficit, but again, we don't know if it's a new onset or if it's there since the surgery or even before the surgery, right?
Correct.
Yeah. Okay. So, Ruli, please, your comments on this case.
Yes, Paulo. Andrew, can you please put the slide with with the clinical symptom again?
There we go.
Yeah, this one.
Can you see it, Rolly?
Yeah. Thank you. Yeah. I a bit confused about inability to walk or stand. 20 minutes. It's do we need direct surgery if the patient come with this, or we can do delay for 2 or 3 month follow up? Because this patient is the please put the slide, the previous one, the screw. Yeah, I think all the screw is in a good position, so I rather to make a long-term follow-up after this patient come, but not to do anything before. I don't know what's your opinion, Paulo?
Yeah, it says in the Dr. Siddiqui says that there is a medial breach of some of the pedicles, but they don't look that bad to me as well. So I wouldn't. If it's a breach, it should be like a minor breach. So that's why probably what Dr. Andrew just said about the importance of EMG can. So if you see like a L5 acute denervation, now probably you can value more the trajectory of the screw, but they don't look bad to me as well.
Can I comment, Dr. Paulo?
Please.
Yes, please.
Yes, I have the same concern with Ruli. If a patient is having some drop foot or drop toes, maybe he can't stand. So I think we have two important things here. First of all, did they try any appliance on the feet, so they make them at a right angle and try to ask the patient to move around. I think that's a very important question to be given. And the other thing is that is there anything in the investigation that says that there is an infection or something like that? Because maybe there is an infection or something like that. That is something that might be the cause. The third thing is that I don't see enough long films that relate the whole spine to the pelvis. So I think the alignment could be another problem, is that this could be something related to the sagittal alignment that prevents the patient from walking properly. These are the three things that pops into my mind when we talk about this case.
Yes, a great point was the AFOs, so ankle foot orthosis with somebody with drop feet. I think that certainly would be helpful to see if this is the cause of the patient's inability to walk. That's a great point.
Yeah. There's also a question here from Dr. Tariq saying that assuming EMGs that show active denervation of the lower lumbar spinal level, could there be any benefit in screw revision? It has been 1.5 years, so will surgery be of any benefit in improving motor power? Do you want to comment, Andrew, please?
Yeah, I have seen that happen where, people have surgery and years later they start developing active denervation at the level of the surgery. It's usually more pain, the initial presentation, than weakness. So this kind of silent weakness is a little bit strange. Maybe it could be peroneal nerve or something else. But I've seen, people develop radicular pain years after surgery. And for those patients, they had good results with removal of the instrumentation. Sometimes, especially in patients who have anterior fusion, and people, I don't know how it is in other countries, but in the US, we use BMP for that. And BMP is notorious for heterotropic bone formation. So over, a number of many years, you start seeing this kind of bone growth into the foramen. And between the screw and between the heterotopic bone growth, you see this kind of impingement on the nerve and this active denervation, and removal of the screw or doing a foraminotomy does result in improved symptoms. But if it's the silent weakness, I am not sure the patient would benefit from that in terms of improvement of the weakness, because it's a very unusual presentation without pain and without decreased sensation.
Yeah. One thing that Andrew said, and for me it is very, very relevant, and I try to stress this particularly when I'm talking to younger surgeons or to residents, is why did the surgeon do this kind of operation? And I think this is the key message. The key message is that nowadays, that I remember when I started my career, like putting a pedicle screw was quite a challenge. So the first concern was if I was able to put the screw in the right position. Now, with or without the technology, it's not an issue anymore. Most of the surgeons can put screws with no major problems. But the main thing nowadays is not if the screw is in a good position, is more if the screw is needed and which kind of stabilization is needed. It's, of course, we don't know the clinical picture before and what makes the surgeon to go for such a long construct. For sure, it's not a very good thing, I would say. At least the alignment is not good. So basically, all this spinal column is straight, which definitely is not a good thing. But more than that, I think that the best chance we have in most of our patients is in the first surgery. So try to plan the first surgeon as appropriate as it is. Do what the patient needs and not what you are able to do. That would be I would say, my backup comment for this case. There's a question from Mario here. Thank you, Mario, for the question. about if there is any study of the cervical spine. Yeah, this is also an important thing I would say, is that when you don't have a clear clue of what is causing the paraparesis, that's what the patient does have. So the patient has a motor deficit, which is not clear, and even if the patient doesn't seem to have first neuron signs, something can be happening on levels above, like dorsal, cervical spine, or even the brain. Yeah.
Yeah.
There's a comment. Kindly show the case. Why? Yeah. That was our comment. Yeah.
Yeah, we don't know exactly why this was done. It says here bilateral sciatica and progressive neurogenic claudications, but I agree with Paolo that this is a very extensive construct for such a small problem. It tends to be very focal, maybe 1 or 2 levels at most. But that's all the information we have.
So probably I would resume your comment, the comment from the panel about have a clear diagnosis before doing any kind of thing. I think particularly on revision cases, this is very important. Is not just go there. Sometimes it's tempting to look there and see, well, this screw is a little bit more medial than it should, but it's weird to say why a patient cannot walk because 1 or 2 of the screws are a little bit more medial. So try to get the big picture, try to understand why the patient cannot walk, think about different possibilities, like peripheral neuropathy, like you were saying about something in the cervical or thoracic spine, something vascular. Try to get EMG, long-standing X-rays, further examinations before going on the surgery and just and doing what has been done without a clear picture, without a clear rationale for what you are doing. That would be my remarks for this case. I don't know if any of the panelists wants to add anything else.
Yeah, Paul, I like to comment for Gibran Tariq question. So I don't think screw revision is will give some benefit in this patient, and also screw revision is the last thing we're gonna do after this kind of long fusion, long screw like this. So if we try to prove is there any correlation with the screw with the other inability to walk is presenting by patient? Now I would like to suggest more another. Is there any CT scan, the new one, Andrew, the last CT scan?
Yeah,
axial.
Yeah, these are all the axials that I have.
Yeah. All this CT scan is looks good to me. So I don't think we need revision for this patient, because like we know together, friends, that the first surgery should be the perfect surgery, because the second will never be the same. And after all, the revision surgery will just try to do to make imperfect fixing of the other problem. So I would do the conservative treatment and follow up for another month, and maybe do more physiotherapy.
May I comment, Paulo? I think the message to be taken home by the participants here is that diagnosis is very important. If you find something on images that is not correlating fully to the patient symptoms and manifestations, don't take it seriously and don't go to surgery. So diagnosis is very, very, very important before doing anything. The other thing is that if there is something that's really hit by screws, it's very unlikely if you revise this screw that it's going to come back. It's, you cannot swear on that. So you put this as a last thing to do. You have to exhaust all other options before you go to another surgery for that patient. I think these are the very important passages to be taken home by this case.
Okay, thank you. There was a question from Dr. Gibran here from Indonesia as well about selective nerve root blocks. Any comment?
The problem with this case is that the patient doesn't really have pain. It's all inability to walk, which is not even clear. Is it claudication or something else? So I would say in absence of pain, I don't see much benefit for a nerve block. Certainly if the patient has sciatic pain, that would be a great option. There's another question from Dr. Khan, if there's a pre-op MRI available, and the answer is no, unfortunately. We don't have this here.
Yeah, thank you. I also agree with that. I think nerve blocks are good for pain, not for deficit, motor deficit. Yeah. Okay, so thank you for all your comments, and we'll go for second case that we're going to be presented by Dr. Ruli Dalan from Bandung, and the case has been submitted by Professor Mohammed Maziad from Cairo, Ain Shams University as well. So shall you present the case from your side, Ruli, or?
From my side, I cannot open Maziad file. Imad, can you help me for the presentation? I will read from here.
I can do it from here as well if you want. So let's see if I can open it. Let's see if I can
so I need your help, Paulo.
Okay, no problem, my pleasure.
Actually, I have it as well. If you want me to share my screen, I have the case.
Okay, let's see if it's working. Is it? It's not full screen, right? Now it should be full screen, right?
Yes, sir.
Yes.
Okay.
Very
okay, Ruli. So, do you want just let me say? So I probably will skip the first definitions and things like that. So, case presentation.
Ruli, you can go ahead.
Okay, thank you, Paulo. Case presentation, this is patient about 58 years old, an active farmer, slim and smoking, and no other comorbidities, diabetic, hypertensive, cardiac, liver, and kidney problem. There is none. His complaint is cured axial pain and radiating pain to both upper limbs with numbness and parenthesis. Recently, he started to suffer from RT side sciatic pain. Slide, please. Sorry. Clinical history: 12 years before, in 2011, patient has suffered similar symptoms and was treated by double cervical discectomy and PCH fusion at C4, C5, and C6, C7 with good and eventual recovery. He resumed his job and field duties and social activities and active farmer. So he's active after that. After the last year, he has progressive radiating pain coming from the neck down to the shoulders, arm, hand, and fingers. Slide, I'm sorry. Then this is the first surgery. Comment on first surgery, please. Pre-operative X-ray study. And slide, please. Yeah, this is the pre-operative MRI, and we can see there's a bit compression in C3, C4, and C5, C6.
4, 5,
but
6.
Yeah, C5, 6. And also in the lateral side is C2, C3, C4. It's look, and C4, C5. It's lateral compression. Slide.
Okay, so just let me. Okay.
Okay.
So this was
this
after the first surgery.
Yes. After surgery, we can see there's a cage. here in C45. Yeah.
Yeah, apparently there are two cases here, one in 4.5 and the other one in C6, C7. There is some thinking there of but apparently it looks like
the lordotic looks good.
Okay.
After surgery, slide.
Okay.
And this is the MRI.
After the first surgery, right? After
the first surgery, yeah, of course, we can see C3, C4, C5, 6. There's still compression and there's some erosion. I think erosion at the bone also.
Yeah.
And
but with
but with slight compression,
Okay.
And the new problem now is increasing pain. But I don't know which is this the same pain like before, or this is the new area of pain? And reduced working power is mean this patient start to feel weakness, less social activities, and left-sided leg pain. Is it sciatica? We don't know yet because it's left-sided only. New investigation first, plain X-ray. And new MRI for cervical spine, MRI lumbar spine to exclude the lumbar disc prolapse, and other investigation is
okay. And
doing it, the nerve conduction study is required. We will discuss about it. And review plain X-ray. Okay. Plain X-ray cervical spine preserve cervical lordosis with a good position alignment at the fused segment C4, C5. Yeah, we can see that. Loss of lordosis at the fused segment at the C6, C7. It's narrowed. The disc is degenerate and space narrowing, osteophyte formation, and compromised root canal at C5, C6. Of course. Slide.
Okay.
This is the.
So this is, please. This is the X-ray.
Yeah.
So we have a fusion there in 4.5 and the 6.7 and a wedge open anterior opening in C5-6, right?
Yeah, the open. Yeah.
Okay.
And it's not. It's now the compression to the cord is even more.
Okay.
And this is
lumbar seems good. Apparently, what they were saying, they were saying that the actual cuts of the cervical MRI was not submitted, but apparently there was some osteophytes on the foramens on C5, C6, right?
It said that.
Yeah, that's what it said, because we could not see it because it's only a midline MRI. Okay. So as I understand, so this is so the patient was good for all these years, and now is developing probably C5, C6. No, C6 bilateral radicular pain, and he has some foraminal compression at C5, C6. That's what I understand from that case. Okay, so what would be your comments or your rationale for this, Ruli?
Yeah, may I look at the last MRI, please? Yeah, it is. I don't know if we have if the patient start to feel weakness here and myelopathy. I think, I don't know, but I will make another investigation. CT scan first, and do the reconstruct CT scan, because I don't know for sure which level that makes the patient become paretic at this moment, now, I mean. And the C4, C5, and C6, C7, it looks bad. And there's there's a narrowing of the foramina from C6, C7. And yeah, I would do the CT scan first and see the stenosis and find which kind of level that's more severe. Is there any information, Paulo, about the most severe level in this patient?
No, I think this is the problem of the submitted cases, that we really don't know. We just know what is written there, and we just have the images that have been submitted, so we don't have all the picture. But according to what has been written in this slide, so there is a narrowing and degenerating disc space with osteophytes and compromised nerve root canals in C5, C6. So let's presume this is the case. So C4-5 and C6-7 are fused. The patient has bilateral symptoms radiating to the arms, and he has some osteophytes compressing the nerve roots of C6. That's what I understand from the case.
Paulo, if I may comment on that, can we, for the sake of the participants, analyze why did that happen to start with? Because I think the decision of the surgery was a little bit weird, because there was a fusion at 2 levels when you knew that the intervening disc is not physiological, and the disc between C3-4 was starting to be affected as well. So I think that's the problem. You were anticipating that this decision to go from anterior aspect and do 2 levels fusion with a skip level, which is pathological as well, and the adjacent segment above the proximal fusion is pathological as well. So this was inviting problems from the start. So what yourself and the other panel would comment on that? I think that's the starting point.
Yeah, just this has been shown. That's why I went back. It looks like this was the follow-up MRI, and the signal change in C5, C6 seems to be here already. So I don't know.
And C3-4 as well was. Dr. Andrew, what do you think about that?
Please.
I was going to ask: is there a pre-op MRI even before the one you're showing?
Yes, I think
this
so.
One.
This one. Yes, and it's here. See, that's.
Yeah.
I think 3-4 was evident to be affected. 3-4 is here.
So I think if you look at this MRI, 5-6 looks okay. So I sort of understand why they decided to skip a level. Now we all know that if you do a 1-level fusion, the adjacent level is at a high risk of degeneration. Now, if you do 2 levels, like Dr. Soud said, and you're skipping a level in between, you're betting on that's going to fail at some point. You're just, keeping your fingers crossed that the patient is not going to survive that long until that level basically herniates and becomes symptomatic. But if the patient lives long enough, that level will become symptomatic. In this case here, that just happened very quickly, because if you go to the next MRI, you'll see that right away, this right there, you have good fusion at 4-5 and 6-7, but then the intervening level at 5-6 is now already herniating. I don't see much canal compromise on this MRI and even on the subsequent one. I think it's all foraminal. Would be nice to, of course, see more images or axials, but it seems to me like it's all foraminal stenosis, and like you said, Paulo, it's compression of the bilateral C6 nerve root. Can you go back to the presentation again of the patient, because a lot of his presentation didn't seem or what the problems he's having don't seem very clear. Some of it has to do with the function or something like that. I think there's a different slide. There you go. So increasing pain, it doesn't say where the pain is. I mean, if we think it's C6 radicular pain, then certainly surgery is warranted in this case. And then the pain in the leg, I would, again, go probably do EMGs for that. I know the MRI wasn't very impressive, but maybe the EMG will pick something like a clinical nerve compression or something else that is, like a zebra in this case. And then less social activities and reduced working power. I mean, some of it might sound like maybe psychological. So maybe the patient should also see a psychiatrist, make sure he's not depressed and having other issues going on as well. But from a neurosurgical standpoint, if the pain is clearly cystic pain, that's a no-brainer. I think the patient needs another surgery at 5/6.
Okay. The other thing I was wondering that if I would like to ask if you think that this could be the question. The question is that I see a signal change in the spinal cord, but I don't really see a compression, as Andrew was saying. So I wonder if a dynamic factor can play can be an issue because it's like a open mouth in the X-ray. No, not this one, but here. So the disc seems quite open in front. So I wonder if a dynamic factor can play a role here.
Yeah, it's
And I
great.
think dynamic
MRI. I don't know if dynamic MRI would even show something.
So I think that's a very good idea. I think also dynamic MRI of the lumbar spine, because the normal MRI is not showing anything and there's sciatica. So maybe a dynamic MRI of the lumbar spine would be beneficial as well.
Okay. So I think we go back to the same things about before treating the patient. We really need to understand the problem and not just doing things there where it's not clear in our mind what is causing the problem. So, but let's just, for instance, because I think that what Professor Maziad was trying to bring up with this case was about option. Let's say the symptoms are derived from a foraminal stenosis in 5/6. Could you go for a fusion or for arthroplasty?
I personally would fuse for sure. I would not do an arthroplasty at this level. I think you're asking too much of this level if you're going to do disc replacement. So I would do, in my practice, I'll probably go anteriorly again, and I would just do a one level ACDF at 5/6.
Okay, Rui?
Yeah, Paulo, I agree with Andrew. We better do the anterior approach, but I think we need to, like Andrew said, that this is, I think it's also foraminal problem, but I don't know. It's multi-foraminal problem maybe, but I'm not sure for which level it is. So I would suggest another investigation for bone, CT scan and cervical first, and we can see all the structure or the narrowing of the foramen, which level, and we can do fusion from anterior for a selective level first. And I don't think it's myelopathy and canal stenosis. So still do anterior, but need more investigation for the bone, and then we can do
Okay, and Saud, would you, if you go, if it's 5/6?
Yeah, I think dynamic MRI first is very important because I need to see if C5/6 is a functional segment yet or not. Also, I'm really concerned about C3/4 actually. I think this is gonna really affect our decision because C3/4, if it is really indicated also for surgery, I would prefer to go posterior for this patient and do either laminoplasty or do posterior fusion with decompression and lateral mass screwing from C3 to maybe not C7 to C6. C6 is not enough, so we would go to the dorsal spine as well. And then this is going, because if C3/4 is affected as well, we cannot do all these fusions from anterior. That would be I think too much anterior surgery for a patient that had 2 surgeries before from the anterior aspect. So I think if C3-4 is affected as well, going posterior and doing something from the back decompression, especially that I see a good lordosis, not specifically at C6-7. It's a little bit flat, but I think there is still a room if C3-4 is affected to go posterior and do lateral mass fixation from C3 back to the dorsal spine.
I think this is an interesting point as well, because particularly if we don't see really an anterior compression at C5-6, so if it's kind of dynamic, dynamic myelopathy, I would say that could be a good option, because you can stabilize and demobilize the segment and also do a foraminotomy, so you can really release the nerve root. The other thing for me that would be against putting a disc prosthesis there is that you have a long lever arm both above and below, so you have two field segments above and below. So I would be unsure about how a disc prosthesis would work with these two lever arms. I don't know.
That's what happened in this case, maybe, Paulo. I think there are a few other slides that they have put a disc and didn't work, and they revised the disc.
Yeah, to be honest, I didn't understand on the other slides. I didn't understand if it was this case, because the levels are not the same. So I would stop here. If any of you can see the chat, because I cannot see the chat because I have full screen here. Just be sure if there are, please.
I can read it for you. So I guess one question: cervical dynamic X-rays not available? I guess the answer is no. We don't have flexion extension X-rays here. Another question by Dr. Roth: I think neurophysiological studies must be performed before making a decision. It seems like the patient has myelopathy in the cervical spine. There are one or two images of it on the MRI. So I guess, what are your thoughts, Paulo, on like EMGs or neurophysiological studies?
Again, EMGs, I don't use them very much. I use them particularly when I'm in doubt if it's a radicular or a peripheral cause. If there is the case, yes, I would do it. Otherwise, I don't know. A lot of EMGs just show chronic things on multi-levels, particularly in cervical. So yeah.
Yeah, I agree.
Or can I give a comment?
Please.
Yeah, there's a question from Mahbub Khan. It's about the posterior. But I would not do posterior decompression, I think, in this patient, because the weakness is not come from the continuous stenosis of the canal spinal, but it's segmental. So the posterior decompression with lateral mass, in my opinion, it will just make it getting worse, because we will ruin the posterior tension construction, and we can do posterior decompression if we have proof that there's a multi-level stenosis. That's why we need CT scan first to find either it's a segmental stenosis or multi-level stenosis, if we don't have the proof.
So that's why really we said that it's going to be the resort if C3-4 is also affected, because I think that's which seems to be affected as well.
Because the compression too early in this patient will make another problem, because we ruin the posterior contraction. So
can I ask a question, Paulo? Do you see any room here for keyhole foraminotomy for C5-6 from posterior?
Yeah, I would say if it's clear, I would say if this patient has a C6 radicular pain, let's say on the right side, probably I would try to do that before doing bigger surgery. But doing bilateral, not clear that it is monoradicular, I don't know. But if it was just, let's say, a unilateral radiculopathy that's clear C6, and on this kind of picture, if it was just pain, I would consider a selective nerve root block, and if the pain fades away, probably that would be an option as well.
Yeah. Okay.
Okay, so let's go for last case, please, Professor Sawood.
Okay, sir. I will, if you just share my screen.
Please.
Can Imad share my screen, please?
Sir, your co-host, you can share your screen.
You can share it. You can share.
I can share it? Okay.
Yeah, you can share.
Okay, just give me a second. Share screen. Okay. Can you see it now?
Yes, just put full screen. Perfect. Thank you.
Okay. So this case was sent to us by Dr. Muhammad Luqman Nul Hakim, Department of Neurosurgery, Hassan Sadiqin General Hospital, Medical Faculty, Badjajaran University, Bandung, Indonesia. I'm sorry, really, if I'm misspelling any of this. I'm sorry about that.
No, you did perfectly, my friend.
Okay. Okay. This is the history of this case. It's 57 years old male patient presented with weakness of the lower extremities. The onset was 3 months before the presentation. Difficulty in walking since 1 month. Numbness and tingling of the calf to the right feet since 9 months ago. So it seems that the onset is not 3 months ago. It's further than that. The numbness and tingling at least are much further than that. So only the weakness is 3 months ago, but the other manifestations seemed to be long term. The numbness and tingling was 9 months. Urination defecation disturbance since 5 months, and the submitter did not say which kind of urination defecation disturbance. Is it incontinence or retention or what? Pain at the lower back that's getting worse at night and better in morning. History of progressive weight loss, 10 and more kilograms in 2 months duration. The electrophysiology shows polyneuropathy mixed type and no known comorbidities. And this is the examination of the patient. Hyposthesia level of S1 and below. Sacral reflex decreased with positive Babinski sign. I'm not sure if this is bilateral or not, but I would suppose that the double pluses mean that both sides are affected. There is retention, maybe of urine. I'm not sure about that. Atrophy, bilateral lower extremities are atrophied, but didn't specify to which level this atrophy is. No affection of the upper extremities, and this is analysis of the weakness, and it shows that the weakness is more distal than proximal, and it seems that the most affected is the ankle plantar flexion, 2/4, great toe extension, 2/4, better a little bit at the ankle dorsiflexion, 3/4, and hip flexion and knee extension are the least affected, 4/4, and it seems that all the affected muscles are bilateral. That's why there is no comment on which side is more affected. And this is the images of that patient, the plain X-rays, AP and lateral, that seemed a little bit of osteolysis around the sacrum, maybe all the segments of the sacrum. We can see a little bit of S1, but most of the sacrum is gone. We can see only maybe the coccyx. And the MRI here shows an osteolytic lesion that affects the sacrum, and it's extra compartmental because I see extension in all directions, anterior, posterior to the spinal canal, and all around. So it is extra compartmental. Maybe we can see a little bit of affection, maybe of the posterior aspect of L5 as well. And we can see both sequences of the MRI to show that lesion. And this is how the CSF flow seems to be stopping before those segments. So it seems that there is a real affection of the CSF flow. There is a canal occupation or invasion. These are all the images that were sent. There is no CT for that patient. And those are the questions. What is the best treatment? I think there is a question before that. What is the differential diagnosis, and what can you do more as investigations before we talk about management? And then the other questions were about the safety of resection and the amount of resection that we can do. And I think this depends on also on our discussion on the investigations needed for this patient to complete the picture and the management options. So that's all the slides I have. Paulo, are you going to ask someone to start commenting on that, or you would like me to do that?
Maybe you can start, Saud, because Ruli knows the case. So maybe we start from you, so and then Ruli before.
Can Dr. Fanous, can I have your insights about that?
Sure. I mean, this can be a lot of different things. With the weight loss especially, I worry this might be metastasis. But looking at the location, there's also a very high chance it might be chordoma. And it could be other tumors, primary bone tumors or metastatic bone tumors. But probably chordoma and Mets would be the top two things on differential. I think.
Dr. Fanous, do you think that this could be a giant cell?
It could be. It's I wish we had CAT scans, but can you go back to the MRI if you don't mind?
Sure.
Just go back.
I'll preface this by saying that I don't do sacral tumors in my practice, but I did a couple of those when I was in fellowship. So
this is the MRI. I think this is the most evident one here.
Yeah.
This is the extension.
Yeah.
This is the extension of the tumor. It's completely extracompartmental as I see it here. Maybe that look to be a wiped out bone is sometimes it might make some confusion between chordoma and giant cell tumor. I don't know what do you think and what Dr. Paulo says about that.
There is a comment, a suggestion from Mario Roth about doing a biopsy before. Which seems I basically don't operate on extradural tumors without a biopsy, so I think it's unless it's just a caldequine or something or a very.
But do you think, Dr. Paulo, that that biopsy is the first investigation to be done here? Because I think there are some other investigations that needs to be done before that. What do you think?
So please share with us.
No, I think angiography, maybe angiography is very important here.
I agree.
And maybe PET scan is very important as well, because we don't know if, as Dr. Fanous said, if this is metastasis, we want to see where the primary is, maybe if there is other skeletal affection, because this might tell you something about even the longevity or the expected longevity of that patient. So what all the panel sees about that?
I
Yeah,
agree
I think-
100%. Sorry, Paul, go ahead.
Please, Andrew. Please.
Yeah, no, I agree 100%. I mean, especially you want to make sure this is not like a neuronal bone cyst or something, which is a little bit far-fetched, but definitely angiography. The last thing you want to do is open this patient up and then start having a liter and 2 and 3 of blood loss and be unprepared for that. CT, in our practice, we don't do PET scans that much. We do chest, abdomen, pelvis CAT scans with and without contrast to rule out any metastatic disease. So that's definitely would be part of the workup for this patient. And certainly if the angiography does not show that this is a very hemorrhagic lesion, a needle biopsy would be a good idea. Of course, if it's very hemorrhagic, you try to avoid doing that because the patient might have some hemorrhagic complications. But certainly biopsy is a great idea before, to know what you're dealing with before starting. But I think Dr. Saud, these are excellent ideas.
So Dr. Fanous, if it is something that's heavily bloody, do you think of selective embolization or something like that before doing anything, even biopsy?
Yeah, absolutely. So yeah, if it's safely embolizable, then yes. Many times when I've seen this when I was in training, the neuroendovascular colleagues would tell us that it's not possible because it's all fed by very large vessels. But if they have small enough vessels that can be embolized, then absolutely.
Can I add another comment before we leave the ground to Dr. Paulo to talk about this? I think if we plan for a biopsy, this biopsy should be planned not only by the CT guys, by the surgeon himself, because the site of biopsy should be part of the incision that is going to be done for this patient. This is very, very important because otherwise this site, if it is metastasis or even anything, even giant cell tumor, it could take this tumor to another part of the skin and we might have a skip lesion afterwards. So I think planning of these even CT guided biopsy should be dictated by the surgeon, not only the CT guys.
Yeah, I think this is a very important remark, and I wouldn't say that for this particular case that should be that important because unfortunately it doesn't look like it's a candidate for an en bloc or a total resection. So, but particularly for cases where an en bloc resection is an option, definitely this is a major issue because sometimes you are doing a big surgery. And since you are keeping the track of the biopsy, you end up having a metastasization or spread of the tumor. So this is a very important remark, particularly for younger surgeons. And again, looking at here, the other thing why a biopsy is important is that I think a good possibility here is being a sarcoma, either chondrogenic or osteogenic. Osteogenic doesn't look that much, but could be a kind of soft tissue sarcoma. And if it is the case, adjuvant chemotherapy can really decrease the size and give you another opportunity for resection or at least for partial resection. So I think, yeah, so there is a comment here as well that is related to what Professor Saud was saying about metastatic workup. Of course, this is mandatory for all these patients. If these patients have lesions all over the body, probably you don't want even to do surgery or so. So definitely this is having a full picture of the case is really very important before just start going there and about the decision. Surgeons tend to think about surgery and tend to think about if I go anterior or posterior or anterior only or combined or whatsoever, but much more important is decision making, much more important than the technical issues themselves.
So you might agree, Dr. Paulo, that this is a case that needs a multidisciplinary team from the very, very beginning. Oncology, the CT and angiography guys, vascular
Imaging.
surgeons,
Yeah.
a multidisciplinary team should take the decision. So it's a matter of tumor board.
Yeah, definitely this is a tumor board. Okay, so we are running out of time. I don't know if there is any further comment from any of the panelists or any question here.
No, it's a great case.
Yeah, it is. Thank you, Ruli. Thank you, Ruli, and your residents for submitting this difficult. Do you have already a diagnosis? Do you have a diagnosis of this case or not yet?
Yeah, we have a diagnosis, but it's still not it's still suspected. It's like a primary bone tumor. I don't know. It's maybe giant cell, like I would say, or maybe chordoma, but it's like, it looks like definitely not metastatic, because it's very metastatic is very rare, come to the lumbosacral region. So maybe it's like a primary bone tumor.
So what you think of, Dr. Ruli, maybe for your management is something like separation surgery, and then what? Because I think separation or debulking or something like that, because with the extension, this extracompartmental extension, I don't think any block resection can do anything for this patient.
Yeah, I agree. Maybe we try to do a biopsy first, and knowing the type of the tumor, but I don't know. I want to ask all panelists here if it's possible to find the correct sample from percutaneous biopsy or just open biopsy, because open biopsy will bleed, but we can take the spinose process of the L5. I think L5, we can take the L5 spinose process to take the sample. But it's still
I think it extended everywhere, Rolly.
Yeah.
We can see here a total posterior disruption, and I think this is easily amenable for CT guided biopsy. It's
okay.
Even a wide pore something. I think that's the only good thing about the extracompartmental extension posteriorly.
Oh, okay.
Yeah.
Okay.
Yeah.
So thank you all for joining. So next spine board will be on the 3rd Sunday of November, which is gonna be on the 19th. So we will send the announcement and also the calls for case submission. So please submit your cases. Though these do not need to be final cases. It can be cases ongoing, just to take this opportunity to have some input on your own cases that you are dealing with, to have the opportunity to have different experts' opinions from all over the world. And I think this is a very good opportunity for all of us. So please submit your cases and participate in the discussions as you did today. And again, it was great seeing you, and looking forward to meet you on the future board sessions. Thank you for joining. Bye bye.
Thank you so much, boss. Thank you, Dr. Andrew, Dr. Hanafi, Rolly, and the submitters and everyone. See you.
Thank you all of you.
So, Paul, Andrew. Yes.
Thank you.
Bye.
Thank you to all.
Thank you all.
Thank you.
Thank you.
Bye.